as you say, James Bullion, President of ADAS this year, and a serving director in Norfolk. And I'm also chair for my ICS for primary care, primary and community care. So I come at this from a social work and adult social services perspective, but also with very much that community-based approach to primary care as well. In the summer of last year, ADAS published 9 statements about reform of social care going forwards, one of which is about locally integrated care built around individuals, which should be the norm. And we think that's based around collaboration and not organizational integration, but really around how we join up around people with a presumption of organizational integration between health and social care, and just have that shared goal of coordination and of pooling where we need to. Of course, it needs to start with people and their individual needs rather than organizations. And we think that the experience of COVID demonstrates there's 2 forms of integration going on here. Health and care is one form, but councils are rediscovering their community roles as a result of COVID-19. So there's an integration around housing and communities that needs to come to the table as well as we think about health and social care. We think this chimes really well with the direction that the NHS were heading in terms of the long-term plan. So it's clear that the NHS long-term plan sees social care as a key partner and sees the person-centred approach that social services and social work takes as germane to that. And there's a really strong emphasis in the NHS plan and in the principle of social work around working in primary care. And for us in ADAS, this really is the goal of ICSs going forwards. We started before COVID with a notion of population management approaches, casework around people at risk in communities, and prevention. There are a couple of problems from an adult social care point of view around that. We don't have much resource for preventative interventions. And of course, primary care was rather knocked off course by the necessity to concentrate on responding to COVID. So we still think we're at an early stage, but actually what COVID has demonstrated and what the discharge to assess processes have demonstrated is that actually, unless you prepare the community for caring for people, you won't be able to achieve better health, better prevention, and you won't be able to free up the resources in the NHS to do what it needs to do successfully with the more intensive interventions that it needs to make. So for us, we feel integration with more resources in the community, particularly with mental health and particularly with disability, has got to be the emphasis of ICSs going forwards on the one hand, and on the other hand, with an ambition to address health inequalities and societal inequality as well. If we can get that vision right around communities, and if we can get the government to fix social care, not just about people selling their homes, but about investment of preventative approaches and around people's independence and around their freedom, if we can get that part right, then social care can come into integrated arrangements with as an equal partner, with the resources to make a difference. So that's our take on what we think needs to happen going forwards. Thank you.
Lovely. Thanks, James. That's great. I'm going to crack on with and go to Ben Collins. Ben is the Projects Director of the King's Fund. Ben.
I'm a Projects Director. I don't do them all. So I've been involved in conversations with local authorities and local health systems at the King's Fund on integration over the last 6 years or so. And I've often got quite confused. I mean, there are so many different ideas in our heads when we are talking about integration. I mean, do we mean the integration of the governance arrangements for health and care systems? the budgets, the decision-making processes. I've often felt that we lost sight in our work on integration so far of the things that really matter to people and the underlying aspirations of the integration agenda. So I guess my big aspiration for the future is to refocus our work on integration on some more ambitious plans for reconfiguring health and care services and voluntary sector services. And of course, you know the problems as well as me. Historically, from the healthcare side of things, we built a health system in the mid-20th century, which was based on a cottage industry of primary care and big hospitals. And then as people aged, their needs increased and the role of the welfare state increased, we started to graft on these little services onto our model in a really haphazard way. So in healthcare, we added our district nurses, our practice nurses, our specialist nurses, our social workers, our occupational therapists, domiciliary care, and so many other things. And we have created this system of the most unfathomable complexity. It's so complex that we've even got care navigators whose job is to signpost our way through the system. And if you're a frail older person like my parents, well, you spend an increasing amount of your time just bouncing from one fragmented service to the next. I mean, my parents' week is spent juggling visits to the GP and the hospital outpatients and the specialist community nursing team. If you're somebody with profound health and social problems, if you're what we sometimes term a troubled family, then you've got the same stream of professionals coming into your life. The police, the social services, the health visitors, the school. And when you add up all of the money that these different services are spending, it comes to hundreds of thousands of pounds, but none of these people turning up at our doors actually seem to have any resources that they can use to help us with our problems. So for me, my ambition is a more fundamental restructuring of these fragmented health and care services than we have really contemplated so far. If you're a frail older person or somebody with profound physical health, mental health, social challenges, then you need to engage with a core team. You need a small group of people who will work with you week in, week out, starting with your priorities and what matters to you. And that core team needs to be able to build a really strong, trusting relationship with you so they can influence how you live your life, and so that they can work out, understand you and work out the things that might really make a difference. We are tackling, when we take troubled families, people with addiction, people teetering on the brink of homelessness, we are talking about really complex challenges, and we need trusting relationships as the basis for fixing them. And we need our core teams of workers, these teams offering holistic care to people with complex needs, to be genuine teams. And by less, I mean, a full-time team, not a virtual team, not people who come together once a week or once a month for a teleconference when the service user is out of the room. We need teams of people, healthcare, social care, voluntary sector, who sit together in the same offices, who constantly share information, who are constantly working how they can adapt who does what to better serve the service user. That's a grand vision. I think it may be too ambitious. It's, I think, more ambitious than what James has just articulated. I have seen small examples of what this sort of reconfiguration might look like around the world and in England. So last night I was talking to the leaders of integrated care systems with representatives of the Alaskan health system. And they closed down all those separate clinics that I described to you. And they put all of their resources into a single multidisciplinary team with GPs, nurses, social support staff, all offering holistic care to the patients, to the people on their lists. In Oldham, there's an absolutely fantastic group of GP practices, Hope Citadel, and they've started with GPs, but then they brought in their community nurses, they hired their own mental health practitioners, and now they've hired their own experienced social workers to provide this intensive team-based wraparound support for people with addictions, people in violent relationships, struggling families, and people coping with severe poverty. I think that's the way forward. I'm conscious that it's ambitious. My sense is we need to expand and support the small number of services around England who are willing to try out that approach.
Lovely, thanks, Ben. And a lot to think about there, and I'm sure we will come back to